Welcome to the next edition of the International Spotlight program for the Aesthetic Surgery Journal. I'm so excited to be here with Dr. Moustapha Hamdi, who is the president of the Royal Belgian Society for Plastic Surgery, as well as the professor and chair of plastic surgery with the Brussels University Hospital. Welcome, Dr. Hamdi.
Thank you, Phaedra. My pleasure to be with you.
Thank you for being with us and also for being an important international affiliate partner of the journal. We hope that you and your members enjoy the articles that we publish every issue.
Absolutely.
Thank you. So as an expert in breast surgery, you've seen many innovations from variations in sizing, trends, types of implants, smooth and textured, ADMs, bioresorbable mesh such as Galaflex, and other products that complement and help to improve breast reconstruction and surgery results. What advice would you give to practicing surgeons in terms of the early adoption of such new innovations versus the wait-and-see technique?
Right. Well, I think this is really a very good question because we are now in an era where we are looking for some new material, some kind of innovation. The breast surgery has been standardized for a while now, but we are looking to improve our outcome. And this comes in terms of introducing material to the breast. Now, the thing in the breast is very specific, that the breast is almost like an organ. So it's not the inert tissue, it's a dynamic tissue. This is why every innovation, every material through the breast should be really tested very carefully before jumping to conclusion and really expose it to the large public. So I must say, if anything new is coming soon or already came out to the market, I expect like more than 70% of plastic surgeons we're gonna adopt the wait-and-see policy. Because of oncological aspect of the breast, the age process of the breast, and so on. So safety is a major issue when it comes to the breast compared to any other aesthetic procedures.
So one of the most written about aspects of breast reduction and mastopexy is maintenance. Do you think that a long-term maintenance of the upper pole fullness is an elusive goal? And how do you approach this issue?
This is another good question. I think this is the word, it's illusion, because upper pole fullness doesn't exist naturally. It does exist in the breast of 18-year-old girl. However, with the aging process, there is no anything called upper fullness. Now, we can divide into two things. We have enhancement and maintenance. And I think somehow we can maintain it by doing certain technique. But enhancing the upper pole fullness is mostly illusion. And I think the only way to enhance it is by either adding implant or fat grafting, which can help a little bit. But all the standard or classical technique, which really presented here and there in the meetings, with this point that it showed that like enhancement of the upper pole fullness, I think is a real illusion. If we are thinking about maintaining this, definitely there is some technique will provide, let's say, longevity of the shape of the breast, and that means maintain also the upper fullness, but not really improving the upper fullness. This is completely something else.
Sure. Thank you. That makes good sense. Now, as a leading expert and innovator, how useful do you think the articles that we publish in ASJ are on topics like these for the plastic surgeon? And, how do you find it relevant to your own practice?
Well, I do believe as a plastic surgeon, teaching and reading and learning is a non-stop process in our career. So one of the methods is, of course, journals. And I must emphasize, our journal, the last decade, get really a very major jump in these issues. It's very, colorful, valuable, but also present up-to-date information. And I do believe that the scientific level will get better because, as you know, an aesthetic surgery is not always to give objective and, a real science, if I can so use this word. But I must say that the level of the articles the last decade get much, much better. And thanks for the difference into the journal and also to the editorial board.
Thank you. We appreciate that. So let's toggle now to areola, nipple areola loss. Whether partial or complete, we know that this is a major complication. It's disastrous. Of the many pedicles that are described, do you feel there's one or two that are safer than the others?
You know, when we come to the such a major complication like that, and I think it's a real nightmare for both surgeon and patient. And I can divide the issue to three factors. It's like everything is like the famous triad. You have the patient, the surgeon, and the environment. So the patient, she might have some high-risk factors like diabetes, smoking, obesity, and so on. The surgeon, by his expertise and choosing a certain technique, might also avoid or decrease such a complication. But don't forget also the environment, that means anatomy. So any technique can really provide a safe outcome. Not every surgeon can provide a safe outcome. So there's completely different things. I never blame the technique. I might blame the technician, that means the surgeon. However, from all actually the review of literature, outcome here and there, I do believe adding additional blood supply to any classical pedicle, that means maintaining the intercostal perforator, would mean the central component of any pedicle. Somehow, attachment thoracic wall will give additional blood supply to either medial, lateral pedicle, inferior pedicle, or even to superior pedicle. Superior pedicle will be maybe the most difficult to keep those attachments, but there's also some way to do it by doing only liposuction to reduce the thickness of the pedicle. Personally, I prefer a technique what I was involved since a long time ago, where it's mainly is either medial or lateral pedicle, however, based on Weringer septum, which means actually the intercostal vessels.
That's really helpful. I appreciate that insight. Last question. In plastic surgery today, we're hearing more and more about the psychological aspects and expectations of patients, and from your viewpoint as a practicing plastic surgeon, the communication that goes on before a procedure. So in our dental rejuvenation section, this is something we've seen several articles on. What's the psychological aspect of the procedures that you're performing, and what are some of the most common misconceptions that patients come in that you feel you need to educate them about?
Well, it definitely depends from procedure to procedure. As a general rule, many patients come to you and use word like, this will change my life, what I totally ignore, and I cannot really admit that. Some people even they come with the idea that this will give them like a perspective, like a new job, like a completely another life. So we have to make their expectation at least real. And then we have also to avoid this kind of a group of patients when come really what we call the BDD, the body dysmorphic disorder, which is not always easy really to explore them and discover them. So I'll give you one example, like a breast implant. Young ladies come to the office and well, this really will change my life. What I always answer to them, well, this is commitment for life. That means once you put such a foreign body in your body, that means you have commitment until maybe either remove it or even after remove it. This is most important that what they can get as a bonus. And I think having probably enough time with your patient in order to explain all the procedure, the pro and con, and all the potential complication for any procedure will help our patient to understand well. It's not, just a very a vanity process or some extra bonus I get it in my life. It's a real medical procedure would have also consequences. Of course, they're going to get a bonus and they're going to, of course, pay for that. But at the same time, it has also consequences and they need to understand about it. One more thing, I do believe that having a setup where the patient will be seen by a UPA, I prefer actually a female one, they have better sense than men, then might also reduce, the risk of the surgeon to have those group of patients with major psychological disorder would become very angry in the end and definitely unhappy patients.
Sure, I think that's an excellent point, and especially for our junior residents and trainees to take away. We thank you so much for being with us, Doctor. Have a really good afternoon, and thank you again for your continued support.
It was my pleasure, Phaedra. Take care.
Thank you.